Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode.
Hello everyone, welcome to 10 Clinical Minutes. Today we're in our OB series on fetal heart tracings. So we're going to start off with some terminology. First off, we have the heart rate, which is the baseline fetal heart rate across a 10-minute strip. If it's bradycardic, it's less than 110, normocardic 140 to 160, tachycardic greater than 160. Variability reflects a degree of deflection off of the baseline. Think about it kind of like the deflection off of an EKG strip. If it's absent, that means that likely something is wrong with the measurement. And so you may need to obtain a fetal scalpel electrode, you may need to reposition the instruments, but you're not getting what you should be getting. If it's minimal, that's a problem. That's why it's in red text. 0 to 5 beats per minute deflection off baseline. Moderate is excellent, 6 to 25, and then marked is treated the same as moderate, but we don't really know what causes it, but doesn't seem to have any evidence of harm. Thus, I've left it blank here in just the black text. Next, we move on to accelerations. That's an abrupt increase of the heart rate that peaks in less than 30 seconds and then eventually goes back to baseline. If the heart rate fails to go back to baseline over 10 minutes, it's a new baseline. That'll be the same for deceleration. Absent accelerations is not a problem, but present accelerations is a positive reassuring sign in the strip. For a preemie less than 32 weeks, that is defined by 10 beats per minute acceleration for greater than 10 seconds, or 1 box on the strip. And then after 32 weeks, greater than 15 beats per minute for more than 15 seconds. Then you have decels, which is very similar, an abrupt decrease, which returns to baseline. If it's 2 to 10 minutes, it's prolonged. If it's greater than 10, it's a new baseline. That's kind of arbitrary because you would treat a prolonged decel in much the same way because you're concerned about bradycardia. Now, those decels have many causes. An early decel, which we'll talk about later, due to head compression, is a pretty normal finding. A late decel refers to uteroplacental insufficiency. That will be a common asking question on rounds that you may need to know the answer to. And then a variable decel is due to cord compression. Both of those are problematic, lates more so than variables because if the placenta fails, the baby doesn't get blood. And so both of those require intervention, which we'll talk about further. And then you have contractions. Those are reflected on the bottom of the strip by the tachometer or by an intrauterine pressure catheter, which is more specific. Normal is less than 5 every 10 minutes. Tachysystole is greater than 5 every 10 minutes. And then adequate, you can only achieve if you have the IUPC in. And that's greater than 200 Montevideo units, another pimping question that's worth knowing about. But you would only be able to calculate an adequate contraction if you have that IUPC. So basics on top, we have the fetal heart strip. Here you're seeing some decels. We'll talk about those in a little bit. You have the maternal contractions. And then on the very bottom, you have a 1-minute interval. Every box is 10 seconds. 6 boxes equals the difference between those thicker lines on the strip. A little hard to tell here. And each box is 10 seconds, so 6 of those makes a minute. So then you have rate, accelerations, and contractions. Here is your baseline rate, kind of an approximated line across. You have your accelerations, which are these pops off of the middle line. They rise in less than 30 seconds, so 10 seconds, 20 seconds, and then they return down to baseline. And then you have your contractions, and this is the maternal contractions that just show nice symmetric increase. Here's another one. And they could be IUPC, which case you can measure it, or if they're just with the external tachometer, then you can't measure the intensity of the contraction. So talking a little bit more about variability, again, table just to show you the details. Minimal variability looks like this. There's a little bit of bounce off of that baseline, but not nearly as much as you would expect. Moderate, you start to see that there's a good increase, 5 to 25. Over here on the right, you have your fetal heart rate. And then lastly, we come down to marked, and you can really appreciate the difference between moderate and marked. And these are the 3 terms. If you're describing variability, you don't describe the amount. In numerical terms, you describe moderate, marked, or minimal. So talking about decelerations, we have an early, which takes greater than 30 seconds to accrue. And these happen with contractions. So as the uterus contracts, it causes head compression. So it mirrors. And as the contraction relents, the head compression decreases. And that's due to vagal stimulation causing transient bradycardia. Then you have late decels, which occur following the contraction. So you have a contraction here, and then the nadir of the decel is after the nadir of the contraction. Compare here, nadir, peak of contraction, nadir, peak of contraction. And again, another contraction, and here's the nadir. Another contraction, here's the nadir. That refers to uteroplacental insufficiency. It is a problem, that's why it's in red, and you do intervene. So if it's recurrent, you can reposition, you can give a fluid bolus, give the mom some supplemental oxygen, which helps with the oxygenation in the placenta, and you may have to consider delivery. Next, we have variable decelerations, classified in intermittent and recurrent. Intermittent less than 50% of the time, recurrent greater than 50% of contractions. And these occur spaced out. It's a little easier to mix variables up with early decels if they're intermittent, because you don't have a ton of them to go off of. And so you really get the difference of a decel based on how long it takes to get to the peak. And this one's a great example. It gets to the peak in less than 30 seconds. So count up here, 10, 20 seconds, about 15 seconds, it's at the peak of the nadir. And this one, actually, you could confuse with an early because it looks like it's lining up, but you have multiple things on the strip. Here's a contraction, there's the nadir, there's the peak. Then you also intervene on these. You can do amnioinfusion if it's an oligohydramnios causing it. You can reposition the mom, give some maternal O2. And those can maybe help resolve these variables. The last one, it's the bad one on the block, sinusoidal, means severe fetal anemia given emergent C-section, called a sinusoidal because it resembles a sine wave. So here's all of them together. You can pause the video and look at the comparison. On the bottom, we have contractions, and then you have lates, variables, earlies, and what an acceleration looks like. Note the difference in time to nadir of a early decel versus a variable. That's an important distinguishing factor. So lastly, classification management. You have three categories, 1, 2, and 3. Category 1 is all of these things present: a normal heart rate, moderate variability, plus or minus accelerations, plus or minus decelerations if they're early, and no late or variable. If it has any of those categories and doesn't have any of the category 3 factors, then it falls into category 2. That's why I call this the garbage can. So you can have one of any of these red factors, or you can have any other combination within this category, and you can pause the video and look at that. And then lastly, for category 3, you have absent variability with either bradycardia or late or variable decels. And then sinusoidal pattern is an immediate category 3 designation. Category 3, you need to do something, and you do something urgently. Category 1, let the mom keep laboring. Category 2, you need to pause and consider. All right, so bringing it all together, now we're going to present the strip. You have the rate, variability, accelerations, decelerations, contraction frequency, and then it gives you your category. So first one, 145 beats per minute, moderate variability, accelerations, early decels, contracting 6 times per minute, category 2, because of the tachysystole. Then you have 155 beats per minute with moderate variability, XLs present, no decels, 4 times per minute, and that's category 1 because it meets all of those prime criteria. Then you have a 90 beats per minute with no variability, no accelerations, recurrent late decels, 3 times per minute, 10-minute contractions, and that's category 3 because it's bradycardic without accelerations and with the recurrent late decels. On the left, we have kind of an algorithm of what resuscitative measures you can take and how you handle each of these strips. Focusing on the resuscitative interventions, you want to improve fetal oxygenation. You can do that by lateral positioning, maternal O2, supplementation, and IV fluid bolus, or tocolysis, oxytocin reduction. If you are in tachysystole and you're on oxytocin, you should take down the bit. You can reduce uterine activity with either tocolysis or reducing oxytocin, and you can reduce cord compression with amnioinfusion or with repositioning. If you do these interventions and the infant continues to have a poor-looking strip, you can consider delivery or consider prompt delivery. These are my references. Again, as always, if you have questions, contact us at info@decodingdx.com. Thanks for being with us and hope you enjoyed the OB series.